Hello everyone, today in our series of Doc Plexus KOL interviews, we have an eminent urologist with us, Dr. Ajit Vaze. Dr. Vaze is currently practicing at Leelavati Hospital, Jaslok Hospital, KEM Hospital, Wadia Hospital and BRC Hospital. He is the past president of Urological Society of India, West Zone. He is also the past president of Mumbai Urology Society, National Coordinator for Female Urology by Urological Society of India. He's also won the Dr. A.V. Baliga Medal, Dr. G.M. Farke Award, organized several first and instructional courses in female urology since 2006. He's also been invited as a faculty by Asian Urology Society at Bali in 2007. He has conducted operating workshop in Dhaka under auspices of BAUS in 2008. He has been invited as a faculty by European Urology for Silver Jubilee year 2010, invited as a faculty for Masterclass in Female Urology organized by European Urology Association, and has been a visiting faculty in 2012 at Vanderbilt University, USA. He is also a faculty for Female Urology for European Urology Circuit from 2010 to 2016. Thank you so much, Dr. Vaze, for being with us today.
My pleasure.
So, do you think alpha A1 blockers is beneficial in the treatment of chronic urinary retention in women?
The answer is no. There is a large amount of data which is available all over the world stating that alpha blockers are not present in females. In fact, there is a large amount of cadaveric dissection which was done by us as well as in the Western world, which suggested that there is nothing entity called as alpha blocker. Especially when the woman is having a chronic urinary retention, the treatment of choice is not to give a pharmacotherapy, but to evaluate her what is the cause of she having a chronic retention. Mind you, the chronic retention in women are almost 10% less as compared to men in that perspective era. And the commonest cause of chronic retention in women, especially in younger women, are a presence of fibroid. And in older women, it is because of procedentia, that means the uterus and the entire pelvic floor is coming down. As a result, there is an obstruction at the level of the urethra, especially mid-urethral level, giving rise to retention of urine. The treatment here is to treat the pathology rather than to give them an alpha blocker, which evidence says, the statistics says, there is no evidence of giving women alpha blockers.
So, Dr. Vaze, can you please tell us about the biomarkers to detect renal cell carcinoma at early stage and what should be the initial management in such cases?
There are several biomarkers, but they are all in a preclinical level. Few of them are all B53, and that is one of the main reasons. There are new markers which are coming in a form of nuclear medicine markers, which will come and hit the market in very quick years, in the next 2 or 3 years.
So, how beneficial is open surgery versus percutaneous nephrolithotomy for the management of multiple kidney stones?
When I started my career way back in 1983, the only treatment which was possible for kidney stone was open surgery. The whole thing changed somewhere in 1986 onward, and percutaneous nephrolithotomy or percutaneous renal surgery got established in 1998 in Mumbai and for the first time, and we all embraced that surgery. Today I'll be telling you that India is the largest or a global leader in training, treating and teaching the people how to do a percutaneous renal surgery. We have gone one step ahead. Gone are those days where the single kidney stones were removed. But today, if you saw the data of CROs all over the world, the largest data hails from India as far as the Staghorn calculus is concerned and multiple kidney stones are concerned. We have also gone one step ahead in children where there are multiple stones. The treatment of choice is still a percutaneous renal surgery, because now we have an instrument which are well suited for children, namely the miniaturization. The percutaneous renal surgery over the last 5 years have seen a radical change. The size has become smaller, the vision has got clearer, our ideas to go in the kidney has become crystal clear. And this has all resulted into very safe surgery, complete removal of the stone, and avoiding the complication to the least for patient as well as patient relation.
So, do you think PCNL offers stone-free rates superior to those of retrograde intrarenal surgeries?
Again, it depends on the indications for RIRS or is totally different as compared to percutaneous removal. If there is a single stone, then less than 1 centimeter, now in last 3 years time, RIRS has become a standard of choice. However, in certain locations of the kidney, namely the lower calyx, still it is debatable, because in India, we all do a very good percutaneous surgery. In fact, if I tell you, out of 100 urologists who passed out in India, almost 40 to 60% are completely proficient in doing a good percutaneous nephrolithotomy once their learning curve is over. Unlike their counterpart in United States, where less than 10% of the urologists perform the percutaneous surgery. They perform more of RIRS, while here we perform more of percutaneous nephrolithotomy.
So, what is your opinion on an online professional community of doctors like DocFlixes?
It's excellent because it not only gives education to the lay people, but also you bring the main people to the mainstream. You find out what is the clarity and crystal clear thought of that, and we also have to give back the services to the society at large.
Thank you so much, Dr. Wazir, for speaking with us today.
My pleasure. Thank you.
Thank you. To stay updated on our latest KOL videos and interviews, please follow us on Twitter, like us on our Facebook page, and subscribe to our YouTube channel. Happy DocFlexing!